Who started with us January 2016, is that right?
Correct.
And he's brought a lot of great things to our program.
Jeff, take your name off the podium.
Thank you,
So I'm going to talk to you a little bit about surgical options for patients who actually have lung cancer. So this is now moving a little bit beyond Dr. Westfall's talk. You know, were found to have a pulmonary nodule, whether it was through a screening CT scan or whether you had an x-ray for some other reason, or maybe you had some symptoms, who knows. But now we've learned that you have a cancer, and we have to figure out what are we going to do about it. Surgery is typically a treatment that is for early stage cancers. Probably you've all heard that before. Cancers are stage 1 through 4. Dr. Seth is going to talk about stage 4. But generally speaking, a stage 1 cancer is something that's only in one spot. It's kind of small. Stage 4 cancers are ones that are spread to other parts of your body. 2s and 3s are kind of a big tumor, or maybe some lymph nodes involved, or some combination of the two. So we're going to be looking at mostly kind of on the earlier end of that spectrum when we're talking about folks who are going to be getting operations. So there are lots of ways that we can handle lung cancers. Most of them these days are minimally invasive. When we talk about thoracoscopic surgery, so this is the fancy word for it. Mostly we're talking about what we call Band-Aid incisions, or very small incisions where we go in with cameras and we take out some part of the lung. The lung is divided into various kind of little subsections, and depending on where the tumor is, we have to remove more or less of it. We do a lot of surgery with robots now, and you guys probably all seen billboards for those kinds of things. Robots have a lot of advantages for certain types of operations. They're not as good for other types of operations. So it's not necessarily the be-all and end-all, but what it really is just it's kind of a form of minimally invasive surgery. So it's a different way of doing these Band-Aid incision operations. And then I mentioned there are different types of lung cancer operations that we do. One of the things that we're doing a lot more about upstate in the last year is this quote-unquote sublobar resection, which means we're taking less lung out when possible to try and preserve lung function. It's a much more technical operation than some of the more standard lung cancer operations that are done, and the fact that we can offer that with a minimally invasive approach is something special at upstate. And so and the last thing is treatment with no incisions, and treatments that are based mostly for folks who have symptoms but maybe are in a situation where they can't have curative treatment. So when we're talking about minimally invasive lung surgery, there are different operations I mentioned. For the most part, the lung is divided into lobes. You got 3 on the right, 2 on the left. Generally speaking, the recommendation is to remove the entire lobe of the lung that a cancer is in if you're going to do the operation for that person. Some folks have less lung capacity than others, particularly people who have had heavy smoking history and some other health problems that can bring that about. And so sometimes there's a strong preference to try and limit the amount of lung you take out. There's a lot of situations where it may not be as necessary as we once thought to take out the entire lobe. Once upon a time for lung cancer, no matter where your cancer was or how big it was, they took the whole lung out. I see a lot of women in the audience. You probably remember a time when folks got breast cancer, their whole breast was always removed. And that's not the case anymore, because we know you don't need to do that. And for lung cancer, we know you don't need to take the whole lung out necessarily. In fact, in most cases, the standard today is to take the whole lobe out, but there's a lot of building evidence that in some cases we don't need to take a whole lobe out, we can take less. So we're always trying to push the envelope and maintain as much lung function as we possibly can without compromising the outcomes for their cancer. Bilobectomy is for a little more aggressive tumors where they're maybe involving 2 lobes of the lung. And so not only can you not take less out, but you need to take 2 out. And that's typically an operation in most centers that's performed through a much bigger incision. That's something else that we can do, again, with Band-Aid type incisions. And even if we do need to take an entire lung out, which is uncommon, we can still do that in most cases with Band-Aid incisions. And that's something that you're not going to see offered in a whole lot of places. Once upon a time, when minimally invasive surgery came out, it was really saved for the kind of most cream puff, if you will, surgery. So the easiest operations to do, the most straightforward. So the smallest tumors, the things most close to the edge of the lung, the things most easily removed through conventional operations, those are the only patients who are offered minimally invasive surgeries. These days, most of those rules have gone out the window, and we can offer minimally invasive operations to folks with tumors in just about any part of the lung. Patients who have had treatments beforehand, such as chemotherapy and radiation, are often still candidates for minimally invasive lung surgery, which was, again, not typically the case. And even folks who have tumors that are getting involved with other parts of the chest. So I mentioned sometimes tumors can involve two lobes, sometimes they can get involved with ribs or diaphragm or even some other vital structures. And even those things not necessarily are a contraindication or a reason not to do a minimally invasive surgery. It's certainly worth a shot at it. You don't really lose a lot. The advantages of these minimally invasive operations are that, number one, we reduce pain. And that's, most people are pretty interested in that. You can see this picture on the side here. You can probably hardly even see the incisions in the back there, but we don't spread the ribs anymore, which is really where most of the pain came from. Your ribs are only about that far apart. If you need to get these things in there, you have to do a fair bit of spreading, and that can cause some discomfort after surgery. So the fact that we can avoid that is really the most important feature. It's not a big factor of how long the incisions are, it's really whether or not we spread the ribs or not. And because the pain is less, we can get people out of the hospital faster. Our typical hospital stay for one of these operations is about 3 days. We get people out even in a day sometimes. 2 or 3 days is not uncommon, and most people are out before 4 or 5, which shaves about 2 to 3 or even 4 days off what typical hospital stays were once upon a time. And then, of course, because of those things, we have fewer complications. The biggest complication after lung surgery is pneumonia. Our heavy smokers are particularly susceptible to pneumonias after surgery, and the fact that we can prevent that more often than not is really helpful for recovery. I mentioned blood loss is less. Visibility is much better with cameras. I joke, I train residents, as most of us do at Upstate, and after we finish these operations, sometimes I joke with the residents, I say, listen, people used to do these operations open. Can you imagine? Because they're so much easier to do with the improved visibility that we can get with high definition cameras and sometimes even 3D imaging. And because these operations are kind of a minimal touch technique, we cause a lot less scar tissue, which can enable us to do repeat operations in the future. You may say, why the heck would I want that? I'm not going to go through this only once. But a lot of our patients are younger these days, and it's actually not uncommon that they develop second lung cancer at some point in their lifetime. And so every once in a while we do have to go back, and it's nice when you can still offer somebody a surgical solution, even years later. And so I just have some pictures just to demonstrate the visibility. You can see this is a minimally invasive operation, and you can see this is a big blood vessel right here, and we can see right down and even see under it where we're working. Whereas once upon a time, when you have a big incision, you can see that scary incision with the jaws of life there kind of holding it open. You kind of have like a bird's eye view, but you're quite far from where you're working, and it makes it a little bit difficult to see. And seeing is believing makes life a little bit easier on your surgeon. You can see some scar tissue here. That's pretty minimal. Anybody who's operated on somebody who's had a big open incision before, you don't get to see nearly that well. You don't see anything. It's everything's kind of glued to everything else, and it can be quite a struggle. And if that's all you've got, that's very easy to separate and almost like you were never there. Robotic surgery, I mentioned, it can be quite helpful for certain types of operations. A lot of people are adapting it as a standard for all lung cancer operations. Most of us can do the operations just as well without them, but there are certain operations which are very difficult to do with a standard minimally invasive approach, and for those we use robotics routinely. I mentioned a sleeve lobectomy here. This is just a much fancier kind of lung cancer operation, and again, most people will tell you has to be done, with the rib spreader and with a big open approach, and may not necessarily require that. And then when we're talking about, again, doing these kind of smaller operations for lung cancer, I mentioned those are a little trickier to do than some of the more standard operations, and being able to offer those with a minimally invasive approach, we think that's pretty helpful. I mentioned younger patients. We may want to save those people some lung capacity for the future, or even now, particularly if they may, God forbid, need another operation in the future. You might be wishing you took out less lung the first time around, so the patient has a better chance of having high quality breathing after their second operation. And it's particularly helpful when the cancer is small and near the edge of the lung. And I just had a picture of here of some really horrific lungs, where they have bad emphysema and big holes in the lungs, and these are people you really want to save every ounce of lung function you possibly can. And some people, these patients wouldn't have even been offered operations because the lung function is so bad. Sometimes we can still do it because we can remove a very small amount of lung and hopefully affect their breathing in a very minimal way. And these are just some of the segments that we can remove of the lung to avoid taking out too much. We also can do a fair bit of surgery for lung cancer without incisions at all. Mostly we're talking about endoscopic therapy, where we're working through the inside of the airway. Mostly this is for patients who are not going to be getting operations, unfortunately, but patients who may be having problems with their breathing because they have a tumor that's in kind of the main airways in the middle of the lungs. Oftentimes those aren't operable. Sometimes they are, but when they're not, we do like to be able to help folks out with their breathing. And whereas once upon a time they might have been given a prescription for morphine, now we can actually do a fair bit of good for people who are having a hard time breathing because their tumors are causing problems for that. Sometimes that involves putting pieces of plastic, what we call stents, similar to what maybe some people have had stents put in their heart to open up the circulation. We can also use stents to open up windpipes. We can also use laser therapy for some patients to kind of burn the tumor away. And Dr. Mix will tell you about, I'm sure, using radiation as an alternative treatment for that as well. These are treatments we call palliative. So we're trying to improve symptoms, but not necessarily give them treatment that's going to kill their cancer or prolong their life. And as you can imagine, that's every bit as important as any of these other things that we're going to talk about today. And then the last thing I wanted to talk about is a newer therapy that we offer here. I guess it's not new anymore, but it's not universally available. One of the problems that can come with an advanced lung cancer is building up fluid around the lung. And that can be a very difficult problem and can have a profound effect on people's breathing. And once upon a time, we did all sorts of uncomfortable procedures to try and take care of that fluid and help people to breathe better. Typically, they involved hospital stays and a fair bit of pain. These days, we use small catheters that can be placed into the space around the lungs to drain the fluid. And these are things that can actually be done in an office without even going into the hospital, don't require a hospital admission, and most importantly, give the patient the control of their breathing. If they feel like they have a little bit of hard time breathing, they have their little tube, they can just hook it to a canister, drain the fluid out, tip it back up under their arm, and they go about their business. They didn't need to call anybody, they didn't need to talk to anybody. Most importantly, they didn't have to go see any doctors. God knows we don't want to do any more of that than we have to. And so, again, something that we offer very routinely at Upstate. And so we've talked a little bit about our minimally invasive surgical techniques. We talked about endoscopic treatment, and we've talked about how to take care of patients with advanced diseases as well. And if you have any questions, I'd be happy to answer them.
So basically, the new advertisement's going to be showing you skydiving, draining your pleural fluid?
I had a patient who rode a motorcycle with it, not necessarily skydiving, but yeah. Most people, sadly, are in that situation are, for a lot of reasons, not in shape for skydiving. But
That's a big commercial.
no, it is. It is a great point because it really is. Apart from the fact that you can't go swimming anymore, it really affects your daily life very little. Nobody sees it. It's tucked up away. It's not like it's hanging out of you and hooked to a bag that's clipped to your belt or anything obscene like that. They're very well hidden. You can still shower. Nobody likes to have a tube hanging out of them, but it is a really easy and convenient way to deal with what otherwise can be a difficult problem. Any other questions?
Does a chest x-ray that they always have you get, before you're having surgery and all that, would that always show? nodule in the lung or,
Oh, no, well, that's not so much a recommendation anymore.
that's what I thought.
Yeah, those, as Dr. Westfall explained, chest x-rays are really a coarse view. We miss a lot with chest x-rays. They're not recommended for finding early lung cancers. They've never been shown to find lung cancers early enough that we can actually do something different about them. That's one of the things why CT screening has been so revolutionary in these last few years, is because it's really the first time, and you think about all the years we've been treating lung cancer, it's the first time we've been able to show a benefit to survival for a screening program in lung cancer. That's important. Any other questions? Okay. Thanks very much.